George Anibaba, and it's a delightful privilege to be working for Health Innovation Care SS in partnership with Sussex Integrated Care System, and in particular the Population Health team on the second series of Population Health Academy webinars. We had our first webinar just last month on cultural competence, which was really interesting and insightful. And we hope to have an equally interesting and insightful session today on quality improvement in population health. A nod to a special day. So yesterday, I just want to take a moment to acknowledge World Children's Day, which was marked yesterday. And this day really serves as a global reminder of our collective responsibility to create environments where every child has the opportunity to thrive. And in Sussex, this resonates deeply, particularly as we work to ensure that our health and care system not only supports vulnerable children, but actively addresses the disparities that they face across Sussex. Today's session will touch on this briefly through real-world examples of quality improvement in action, showing how these principles can make a tangible difference in children's lives, but the lives of everybody that is experiencing or that has a health need or health and care need. But I also wanted to hop on my soapbox briefly. So last session, you'll remember me mentioning the NHS Constitution and the NHS Constitution values. And one that links to this session, namely the one on quality improvement in population health, is commitment to quality of care. And this value speaks directly to the heart of what we'll discuss today. So quality improvement, for those of you who are seasoned or brand new to it, it's more than a set of tools or strategies about, striving for excellence in everything that we do, but making sure and ensuring safe, effective, and compassionate care for everyone in our communities. So essentially, it's about continually asking, how can we do better? And then taking action to make those improvements. But I'm not going to talk about quality improvement because we've got some experts who will do that and people with lived experience in terms of work they've undertaken, and they will bring this to life. So they'll share some practical examples, some insights, and some strategies that we can all take back to our own work. So as you listen, I encourage you to think about how these approaches could apply to your own context, but I'm sure the speakers will encourage you to do the same.
So today we're going to be talking about quality improvement in population health. And this topic is truly at the heart of the work we do as a health and care system, and indeed a cornerstone of our ambitions to build a healthier, fairer Sussex. But as we look at the challenges and opportunities across our ICS, one thing is clear: health inequalities persist. We know that in one part of Sussex, in one of our places, that people die 14 years earlier than other people who live in the same place, in the same locality. We also know in the other two places that we have people who die 7 years earlier than others. So there are real disparities in life expectancy, which we are tracking now, and we really need to make efforts to address those and improve access to care and improve their outcomes. Now, these differences are driven by deprivation, ethnicity, and other social determinants of health. So why does QI matter, quality improvement? So quality improvement matters in healthcare, and why it's so vital for population health is because it's core to what we do. If we don't improve what we are doing, then we will never change the outcomes for our population. It's about making things better. It's about taking a structured, practical approach to improving the way we deliver care, tackling inefficiencies, and ultimately achieving better outcomes for the people we serve. But when we apply QI to population health, it becomes even more powerful. We're not just not improving care for individuals, we're addressing the bigger picture, the population. And that's the difference around the population health. It's about the population that we serve and making it better for as many of those people within that. Tackling the health inequalities and creating a fairer system, an equitable system for everyone. Nationally, the importance of population has been growing, and you will know that through the last few years and especially through COVID. And key policy drivers like the NHS long-term plan and now the 10-year plan are all driving us further to keeping our eye on reducing inequalities and highlighting its central role in what we do. In Sussex, we have our shared delivery plan, and that's reinforced in a number of the areas across all the different areas of focus. But there is a specific area on addressing health inequalities, which really focuses on the core 20+5 outcomes that we need to address. So there's clear the work that we're doing, not just on the core 20+5 priorities, but also in other areas like elective care and maternity, which really need to make sure that we look at it from an equitable focus. Sussex has a rich history of quality improvement. I'm sure I'm not alone in saying there's been fantastic projects over the years that have delivered real benefits, from improving access to care to enhancing patient experiences, and I'm sure you on this call right now have done that yourselves. But we need to think bigger. I've referenced the 14 years healthy life expectancy gap that we have within Sussex in certain places. So we need to look at how we can address this and harness the tools and skills and strategically look at our workforce to embed QI into everything we do. So I'm really pleased we're doing this webinar today and other webinars that we do also to help you on that journey. It's a chance to reflect on what we've achieved so far and to learn from colleagues who are leading the way, and specifically focusing on children, which is great. We often neglect children in a way, although they're a key part of our future and a really important part of our population and our families. We all want to help our children. So it's great that we're looking at children today. And they'll show us how we can use QI to grow confidence and build capability and make real impact. So quality improvement is the lever that turns insight into action. It's about using structured evidence-based approaches to test, learn and refine changes that improve care. But beyond the technical process, it's also a mindset. It's a commitment to continuously improve, to collaborate across organisational boundaries and to put people and the population at the centre of everything we do. So the Population Health Academy, our role, the reason we've established this for Sussex is to play a critical role in this journey, to equip our workforce, yourselves, ourselves within NHS Sussex as well, with the tools, knowledge and understanding that we need to tackle health inequalities, build trust with underserved communities, and improve outcomes for everyone in Sussex. So this is our moment to make a tangible impact, and together we can reshape the future of healthcare for all with this ongoing commitment to improving care for our individual patients and therefore our population. Thank you, George.
Great, thank you, Sharon. Great, thank you. So yes, so during the first year of the system-wide webinars, we introduced the 10 core principles for health equity, which were developed by our Chief Medical Officer, Dr. Mary-Anne Farroux. So the 10 principles recognise that there are multiple drivers of health inequalities and that promoting health equity is complex and that it needs to be tackled from multiple angles. So drawing from the latest best practice and evidence, the principles provide a framework to consider in what ways people may be disadvantaged and what action can be taken to address various barriers that people may face. So as part of this year's system-wide webinars, we'll be diving deeper into each of the core principles. And at the first webinar on cultural competency, we provided a spotlight on the principles of policy and comms. And if you missed that webinar, you can watch it back, which should be available on the Population Health Academy website. And yes, the slides will be made available after. So today we're exploring health equity in the context of quality improvement, or QI, in population health. So QI is about using systematic, evidence-based approaches to make care better, safer, more efficient and more equitable. So when we apply QI in the context of health equity, it becomes a powerful tool for ensuring that care reaches everyone, especially those who have traditionally been underserved or face barriers to access. So today we'll be exploring the principles of care and clinical through the lens of quality improvement in population health. Next slide, please, Sharon. So care is about co-designing solutions and ensuring that a diverse range of people who are representative of those who use your service have been meaningfully engaged. In the context of quality improvement, it's about seeking a range of views to understand what the challenges are for different people, how different people use and respond to services, and recognise that one size doesn't necessarily fit all. So through seeking a range of views and co-producing solutions, this will ensure services will better meet the needs of communities that use the services, as well as increase access and improve experiences. Co-production enables wider considerations to be brought in that may have been overlooked and for services to be modified based on patient needs. So one kind of example or tool are using patient experience surveys. So they're a good place to start to look at the ways in which different users are experiencing the service and to hear both positive and constructive feedback. And this will guide areas of the services that need to be improved and looked into further. You can also use patient experience surveys to monitor changes via the feedback provided once a service has been modified or implemented. Next slide, please, Sharon. So clinical focuses on embedding equity into clinical care by recognising and addressing disparities in health outcomes and access to treatment. QI uses data to shine a light on inequalities like variations in treatment outcomes or access to diagnostics, and enables clinicians to design targeted interventions. By continually evaluating what works and refining practices, QI ensures that clinical care evolves to meet the needs of all patients. So this principle further reinforces the need to engage the workforce and seek feedback from those delivering and managing services. And through engagement with the workforce, you'll be able to understand how services are being delivered in practice, what the challenges are, and areas that could be improved. So feedback should be sought from all of those involved in a delivering service. And you may wish to understand what workplace factors may be perpetuating health inequalities and what changes can be made to mitigate these. You want to consider how will changes to the service reduce disparities and improve quality and experiences for both staff and patients, and what workforce education or training may be required to improve the service. So it's important to not only seek feedback from the workforce, but also to support multidisciplinary teams that can identify improvements and continue to champion implementation. Next slide, please, Sharon. So I'm really pleased to announce that today we've published a new Commissioner's Guide to Health Equity. We published earlier in the year Innovator's Guide to Health Equity. So this guide builds on the 10 principles for health equity and provides tips to support health and social care commissioners in promoting health equity at every stage of the commissioning cycle, from strategic planning to procuring services all the way through to evaluation. The guide also provides a health equity self-assessment tool which can be downloaded and can be used to record the ways in which health equity has been considered in relation to each of the principles and throughout the commissioning cycle. So do have a look at this after the webinar and share with your colleagues, and I'll also put the link in the chat during today's presentation. Next slide, please, Sharon. So included in the Commissioner's Guide and one example of QI in action, which supports both the care and clinical principles, is Diagnostics, who are an innovator we've worked with and who have been very successful in embedding health equity and continuously seek ways to make improvements. So Diagnostics create and deliver test and service platforms that enable the early detection of diabetes through screening of at-risk individuals. They use wireless and sensor technologies to enable safe and secure diabetes testing at home. Next slide, please, Sharon. So from its inception, Diagnostics have identified and embedded mechanisms to continually seek improvements and ensure that as many patients can access their innovation and ensure it can be effectively implemented within the NHS as well as within existing pathways. And they've been able to achieve this through close collaboration with commissioners, the workforce, and patient groups. So in order for co-production to take place, Diagnostics engaged with a wide range of stakeholders, such as nurses, clinical experts and leaders, and patient groups. They carried this out through focus groups, on-site visits, at conferences and network meetings, and they undertake continual user testing with diverse patient groups, which has enabled product improvement and increased accessibility to the at-home glucose tolerance test. They've found that in external trials, as well as in routine use, the at-home test is proving to be easy to use by all women when they're being booked tests by antenatal staff. And to identify pathway improvements, a designer from Diagnostics was provided access to several clinics so that on-site clinical pathway assessments and analysis could be conducted. And through this, they were able to seek and identify improvements that could be made to maternity care and when implementing its system for routine use. So to ensure the workforce were confident in using their innovations, they provide in-person and online training to upskill staff and provide a helpline where staff can call with any questions that they may have. So through ongoing monitoring and evaluation, Diagnostics are able to continually adapt and make improvements. They do this through compiling data regarding uptake in the NHS, including for accounting for ethnicity and socioeconomic status. And this has helped identify patient groups who might not be taking the test up at home. And they have then been able to identify mechanisms to better support uptake of the innovation, such as working through community outreach teams who then attend the person's home and support them in taking the test, as well as submitting the results. So Diagnostics is just one example of how our QI principles can bring health equity to life. It's not just a technological solution, it's a way to rethink how we deliver care, ensuring it's patient-centred, accessible and designed to achieve equitable outcomes. So as we hear from our next speakers, do think about how these approaches can be applied in your own areas of work to make population health everyone's business. If you just go to the next slide, Sharon. So just a couple of links to the principles and the Commissioner's guides. And if you'd like to get in touch, then my email address is also included. Thank you.
So as George was mentioning, I'm the Head of Quality Improvement at the Royal College of Paediatrics and Child Health. I have worked for the last almost 20 years now in researching and evaluating quality improvement methodologies and being a QI coach for organisations like Nesta and the Royal College of Surgeons. I am not a population health specialist per se, but these methodologies are relevant for population health as much as any other improvement area. I'm going to give you a summary of what we mean by quality improvements. In essence, what the core aspects I believe are effective to follow and important to follow in order to maximize your chance of improving outcomes for those most in need and sustaining that over time. And to reiterate that this is a mindset, and there's a natural contradiction in all the conversations we have about QI in that this is a marathon as well as a sprint. And often you're told, okay, you must do a QI project, and you're told to go away and do a QI project. But in fact, in order to develop sustainable QI, you need to be doing multiple ongoing continuous projects that align with what other people are doing and doing that in collaborative. So that can sometimes be daunting, but the essence of what I'm trying to say is that if you follow that mindset and try a few practical steps, then it gets easier the more you do it. So this is a feeling that I certainly have very regularly, and in all my work in QI, this comes up a lot, in this feeling that that Christopher Robin is describing, this is from Winnie the Pooh, saying, as Edward Bear is coming downstairs, bump, bump, bump on the back of his head behind Christopher Robin. It's as if, as far as he knows, the only way of coming downstairs. But sometimes he feels there really is another way, if only you could stop bumping for a moment and think of it. So that, in essence, is what we're trying to do with quality improvement, is to provide a structure for people to be working collaboratively together in order to achieve improvement. So for those who have worked in this at any point, you'll get different definitions and people having slightly different approaches. This summary that Paul Batalden and Frank Davidoff wrote in 2007, I still think stands up as the best definition of what we should be meaning when we say improving the quality of care. So it's the combined and unceasing efforts of everyone, be they healthcare professionals, patients, their families, researchers, payers, planners, educators. So everybody, basically. Remember, this is written by a couple of American health services researchers. So that's the nature of their list. But they're saying that we all need to work together to make the appropriate changes to achieve better patient outcomes, professional development, and system performance. Now, at the Royal College of Paediatrics and Child Health, we're boiling this down to say, okay, we need to be using structured approaches, and this is something that Joe was referring to as well within Sussex Population Health, and that it's the structured approaches which is quite fundamental that I'll go on to in a minute to sustainably and equitably improve the quality of paediatric healthcare and child health. So this is specific, that outcome there is specifically RCPCH. You can change that outcome to be whatever area that you're focusing within population health. Importantly, that this structured approach is not just taking a hunch, like I've always found this as a problem, let's just go ahead and do it. It's building upon the best evidence of what's working within particular contexts, within particular situations, what evidence about what other people have done. So something that happens a lot in quality improvement is that because it's about doing action in your context, people reinvent the wheel the whole time. So one important step to do is to go, okay, I have this problem. What have others done? What can I learn? So when I try my change, it's building upon that best efforts. It won't be a one-off, but let's just start with doing that one thing, and then let's think about the other things later on. So it's a marathon and a sprint. You can do QI on your own, but for it to be sustainable and making a difference, particularly at a population level, it needs to be in partnership. So that's talking to the people who are going to be affected by this. So that in child contexts is with children and young people, their parents, your colleagues, your bosses, etc., getting that agreement of what the common problem is to focus on, and then working in partnership together. That is often quite difficult to do, but the most successful quality improvement work is in partnership. Not just theory, it's temptation for us to just, let's just talk about this for a year, and the traditional kind of organizational change is, okay, let's develop a SOT, let's develop a business case, let's spend a year on this, and then we become invested in it's Jonathan's thing that we must do, and then it's less likely for me to realize, okay, this isn't working, let's do something else. So there's an aspect of just do it and then iterate. And the last point I'd make is that it's a belief, so you have to have some measurement in there. So I'm going to go into more detail about this, and this is something I've touched on already around this important aspect of equity, that it's more than just improvement. Equity and variation is key. And I strongly believe, and evidence is suggesting that if you're focusing on those most at risk of harm for those who have the poorest outcomes, if you increase and improve the outcomes for those people, there's an overarching population improvement overall. Okay, I'm going backwards here, my apologies. The importance of sustainability. So the word quality improvement suggests that you're just always going upwards. Sometimes it's a question of embedding, normalizing, and sustaining, which is where this marathon comes in, that if you have an idea and you do end up getting a bit of an improvement, the next thing is, okay, your next task, your next goal for improvement is, okay, can I keep that going? Can I sustain it? Can I embed it? Can I make it so people turn around and go, yeah, we've always done it this way. If it's the right way of doing it, then that's success for you. And then it's using these structured approaches. So invariably, and I'll go into this a little bit time, what gets called QI is often time-bound, rapid demonstration of improvements. There are other more systemic methods that we could use, but generally when we're talking about QI, it's most effective when you're having time-bound demonstration of improvement. There is no fixed method. You get people saying, oh, you must use the IHI 3 steps and improvement methodology. You must follow PDSA cycles. Slightly sacrilegious in some circles to say this, but that is not true. You need to match method to the situation. Application of scientific knowledge is essential. Understanding of context is essential as well. Using implementation skills and measurement and learning are the key factors. You'll understand here that I'm repeating myself slightly, but they're the difficult things that sometimes you need to keep on asking yourself, going, okay, I've done these things, but I haven't looked at context. I've done these things and I haven't looked at measurement. So they're the important factors. So In terms of QI steps, I'm sure that Sussex Population Health might have a similar model. There are lots of models of, okay, what steps should you be following? I've just put two up here because they're the ones I'm most familiar with. One of them is something that the RCPCH developed over the last few years, which is a module that you can find on our QI Central website with a link there to that module, explaining sort of steps that you could follow for quality improvements. The one on the left here is something that I wrote for the Royal College of Surgeons a few years ago, which is largely following similar steps. And however people are talking about it, it's always going to be following similar aspects of you need to understand the problem, you need to develop ideas that can be measured, you need to go ahead and test that with measurement, and you need to iterate. So those steps I mentioned earlier, they're largely going to be the same every single time. So you just follow those steps. It's easy, okay? But this goes back to the points I'm making before on the, you will find people you work with who are saying, hang on, let's get this perfect. And then others just going, let's just bulldoze through. It's important to get that right balance, to talk to children and young people, to talk to your colleagues with decades of experience and say, okay, how should we approach this problem, but not to do too much talking. So that first step of going, okay, how do we build enough information to understand what that problem is going to be so important. Secondly, almost always, if you go about doing improvement, your bosses or your colleagues, you go, yeah, great, go ahead and do that. And then you'll find out that you're on your own and you're doing that on your own. Find a couple of allies to work with you. This image is what you don't want to end up having, but as you go ahead, the more you get used to quality improvement, you're going to continually find occasionally going, hang on a second, I'm the only one doing all the work here and everyone else is going, good job. Now, sometimes you might have to just keep on plowing through, but if you can find some allies to get involved with you, there's an image which I haven't put up here because I've got enough slides already of the difference between your core group, your allies that need to support you, that have the levers of power, and then the people that you need to occasionally get involved in. If you can make sure that core group isn't just you on your own, then you're winning. Then around measurement, there's a danger that you can go too far one area or the other area. In that firstly, you can think, okay, well, I must get the most amazing measurement metric for the thing that we're doing. This is where this image, which again, I'm saying you shouldn't be following this, get all the information you can think of and we can find use for it later. That's not the way to go about it. What are the single things that will tell you at the beginning of this where we're at, as we're going along, are we changing? Ideally, you want time-bound measures, but even if it needs to be narrative, that's better than having no measures. So even if you talk to your colleagues and saying, how is the situation right now? For example, in this workshop, we've said, okay, what's your understanding? And then afterwards you go back and say, what's your understanding? Having that narrative information, that qualitative data, is sometimes good enough. And then again, going back to there will be times that you feel, okay, this is exhausting. If you just keep on doing the little things, then you'll find out that things will change well over time. So what does this mean in practice? I'm going to focus on a couple of these things on the red area of exploring and discovering, then the blue area, or the turquoise area, and then the dark blue area. It's important to stress all models are only useful in a particular situation and are not perfect. This is a linear model, and I spend most of my time in other contexts persuading people that improvement isn't linear and we need to be taking this in a more systemic and human factors approach. However, if you're new to quality improvement and for particular areas, these are key questions that you should be asking yourself. So difficult to present things in a way that isn't linear, but just remember that improvement is cyclical. So on this first one, agreeing that you have a problem and there's agreement with your peers that it's a problem that needs fixing. is super important. Measurement is super important, and then going ahead and testing. So in summary, it's like building the will, developing your ideas, and executing. So focusing on this first one, it's slightly frustrating here. I couldn't find the pink color when I was just doing these slides, but slightly red. But what we're saying here is find the lowest hanging fruit that you can all agree on. So something that is important for focusing on. You must understand your particular context and matching that approach to the type of problem you have. I'm going to talk about some of the kind of frameworks and background of what works in QI. There's no need, we haven't got time to go into massive amounts of detail, but this is a bit of a snapshot of things that could be useful. This guy, Donabedian, often gets referred to by evaluators and researchers rather than QI specialists, but I do think it's a very good frame. And there are other ones that you could use, like a Cynefin framework or work that Barbara Zinnemann has done on understanding the nature of a problem. But this one, I think, as an adapted Donabedian framework is really useful. So what Donabedian was saying is basically any change that you're doing, they're either structural changes or process changes, which will lead to outcome changes. And if you understand structure and process, then that will tell you how the outcome is changing. So when you're looking at evaluating, you need to look at structure, process, and outcome. A lot of the work, so this was over 50 years ago that Donabedian came up with this. A lot of work from improvers has been developing and adapting that framework to say that culture and behavior is super important as well. So when you're talking about deciding on your QI problem, I find this really useful to say, okay, is your problem a structural problem that you need to build more buildings, you need to have more staff, you need to have more equipment, the formal organization of your team needs to radically change. That's very hard to change quickly. And there are the kind of more traditional QI methodologies are not necessarily appropriate to that. You can use QI to those structural problems, but it's a bit of a bigger presentation on how you'd go about that. Then there are process things, so your access to care, transition between services, systems to manage flow, for example. And forgive me, these are quite often not population health specific. We understand it's problems which are processes that can be improved. This is ideal for QI testing, as is changes in culture and behavior. So how people are engaging and owning population health goals, nurturing your environment that makes it difficult for you to do your job and improve outcomes. The difficulties of having a true agency for patients and children and young people. So often your QI change might be on improving culture and behavior. It's important to recognize which of those they are because you would use different approaches for them. Moving on to this turquoise area, there are certain tools that can help. I find that some people use different methodologies than others. A couple which are really useful for you to use, particularly if it's the first time you've gone about this work. First one is the use of a simple driver diagram. So the idea of a driver diagram is to elicit your theory and plan out with your colleagues. So that, remember that team that you've been working with, how do you get that understanding? You may have different approaches, you may have different beliefs and different knowledge. If you elicit that and document it, then you can start planning out what the ideas you would have for change. So a typical driver diagram is you're developing your goal, which is measurable in a particular time. So this particular example is reducing referral waiting times by 50% to 8 weeks for children referred to a ward by March 2022, which happened to be taken from an epilepsy improvement program that we were involved in a few years ago. Then you develop your drivers of going, okay, what things need to happen? And there may not be things that you in your direct control, but what things would need to happen in order for that goal to be achieved? Then you develop your secondary drivers of things like, okay, in order to achieve those improvement in diagnostic services, what would you do? And then spend time going, okay, let's just brainstorm of things, ideas that we could test. So it's a mechanism for putting down on paper what some of your ideas are linked to your goal. Again, I wouldn't spend months on this, but it's like getting that down on paper so you can agree, okay, let's focus on this particular change because it's got the most chance of affecting the goal and we can measure it. Let's do that for 3 weeks, let's do that for 2 weeks, etc. So that's one tool which could be useful. The second tool is the IHI model for improvements, which is good at similar, but good at working out that you're documenting what is the aim that we're trying to accomplish. Do we know that, how will you know that that change is an improvement? So is it possible for you to measure? And then what changes will be resulting in improvements? So going through the process of asking yourself those 3 questions can help in your design of what QI program you're doing. And then the plan, do, study, act cycle is something that is useful in some contexts, but the essence around it is that it's going ahead and doing something for a particular amount of time and then stopping after a particular amount of time and going, okay, did that make things worse? Did nothing change? Did it make it better? And then shall we iterate? So at the very heart of this is you may have answered those first 3 questions, but then just go ahead and do something for a particular time and then reflect and review on it afterwards. This improvement guide is quite useful for people to look at and go through in a little bit of detail. And finally, on the testing, I'm just going to do a little discussion around measurement. Now, bear with me here a second, because this is getting in the weeds a little bit around improvement, and particularly in healthcare, we get quite obsessed with doing things like audits or pre-post measurements. Now, if you're trying to change a process or you're trying to change behaviors, having time-based improvement really helps. And this paper by Perlow and Provenost and Murray, so I shouldn't forget him, is a really good illustration of how you can present the same data. So on the left here is pre-post of over a particular time where you're just saying things moved from 70 to 30. Doesn't matter what the thing is, but it's there's a change over time. And then the charts here is providing exactly the same data over time. And there are 3 different things that are happening. The first one here is that there was steady improvement over time with something radically changing with that particular change. The other one is it's consistently happening. So when the change happened in June, there wasn't any effect of that, but something was already happening. And the third one is that there was no underlying change happening, but then when that change happened in June, that is the thing that made the difference. But you wouldn't know that from the pre-post. So ideally, you want to have some form of pre-post data. Now, within healthcare, you often get things like, oh, you have dashboards with everything going red, or you have complicated reports, or the biggest bugbear of people working in QI is let's present a pie chart because it looks visual. No pie charts. So if there's anything you want to have as a tattoo as a QI specialist of going, we don't do pie charts, I think would be a good thing to do. Can be super simple. It doesn't have to have a big database, doesn't have to be electronic. It can be on a sheet of paper, time and number and volume, and tracking that over time. And then as you're getting more complicated, you can go into sort of build that reliability and have statistical significance that you can prove that things have changed. But we haven't got time here to go into the detail of how statistical process control methodology or run chart methodology. But in essence, tracking something over time and measuring, okay, we did something here, and actually look, we think there's significant change here. I'm now going to contradict myself slightly here, saying that, but this is ideal. But if you can't do that, narrative is better than nothing. So, in summary, if you do one thing, it's give it a go. So, try having conversations with your colleagues, agreeing on what is that lowest hanging fruit. Can we test this over time? Have a little go with the driver diagram, or using the IHI model for improvement, or you're just documenting, okay, I'm going to try this for these number of weeks, aiming for this outcome, and I'll be able to measure it this way. And I think that's my time, George. Just to leave time for questions and discussions.
Thank you very much, Jonathan. And yeah, how insightful and a practical exploration actually of quality improvement and its potential to improve and transform. So you've highlighted some critical points that resonate deeply, and certainly resonate with the challenges and opportunities we face in Sussex. So one key takeaway from what you've just shared is how QI isn't just a method, it's a mindset. And obviously the other thing you brought up as well is that it's a team sport, just like population health is. From your experience, I mean, what have you noticed being the greatest barriers, particularly working across sectors, if people are taking a multi-agency approach to improving outcomes? And certainly when we're taking a population health approach, you'll have people from various care settings that are not necessarily in the same geographical teams, but they might be in slightly or organizational teams. They might be in different organizations, but working towards the same goal. From your experience, what have been the biggest barriers and challenges to getting teams from across organizations or sectors to try and test things?
It's the nature of kind of projectitis, and there's significant amount of research in either in international development or healthcare improvement or in any area, that it's a difficult persuasion piece to say, yes, we agree that this is the overarching problem, and we're going to work and put resources in for this certain amount of time. But if we don't get hardcore results after a year, we're going to say, ask questions of, okay, maybe this methodology doesn't work. And we have to remember that the QI as a methodological approach is in its infancy still. So healthcare improvement has only been used as a methodology since began to be used in the US in the late 90s. And then people say, okay, well, does it work? So for example, the surgical work that I've been involved in 2016 is one of the few programs that is now finished its 4th collaborative round on the same problem. It's a very simple problem of there's loads of evidence that surgeons should behave differently and operate on people's gallstones quicker. And we managed to demonstrate on the first collaborative round that using QI methodology works. However, to build enough momentum with people to stop trying to do the thing which we know doesn't work takes multiple iterations. So some of the sites have truly embedded sustainable improvement. They've done it 3 times and it costs a little bit of money. Now, in the landscape that we're in, to turn to ICS colleagues and go, okay, we need to, in order to improve population health, we need to be spending time and energy on these improvement methodologies 3, 4, 5, 6, 7 different rounds. Now, that doesn't mean it doesn't work. So I've also been involved in programs and saying, well, you've trained 100 people in QI methodology in this area, and we haven't proven that this has improved. So we're not
Mm,
funding this anymore. So one of the biggest challenges is to recognize that marathon and the sprint piece, and it's not easy. So yeah, that's a long answer, and it's not providing a solution to it. It is good that we're having sessions like this, but that's not good enough. We
mm,
then need to provide support. And when I say we, that's organizations like professional bodies like the RCPCH, but it's also ICSs, it's also the innovation hubs. It's all of these. We all need to work to support each other to go, let's keep on going on this.
mm. Thank you, Jonathan. I think it's a reminder again, a reassuring reminder actually, that even small incremental changes can make a big impact, but it's not a one and done piece. You might have to try and try and try and try again. But you might have to make a recognition that, you know what, this actually isn't working. Let's try something different. And that's again part of the rigorous testing and adapting to local needs. And I've seen a couple more questions. You could probably take one more. There's one, Jonathan, on brief guidance on the cultural element on trying to achieve better outcomes. I think that's Jill mentioning that this is one of the toughest barriers and yet not easily quickly defined. So if there's any brief guidance on the cultural element on achieving or trying to achieve better outcomes. And there was another question on reflections on of how QI principles and methodologies can be applied to commissioning activities. But mindful we're going into our break, but I don't know if you wanted to attempt to answer at least one of those questions, one around culture and one around how it could be applied to commissioning activities.
So the cultural piece, there are some good frameworks. I haven't got the link in front of me, but I can send it over to you guys that the Health Foundation were doing around habits of an improver, which have then been built up within the NHS, which provide that good structure that learns from the literature around learning and leadership over how you can build change. There's a lot of good literature within the advocacy area, but using slightly different language on something which, again, within healthcare, it's quite difficult. Oh yeah, habits of improver, brilliant. Um, that is difficult for us to admit in that evidence doesn't change people's behavior and doesn't build cultural change. And also working working directly on creating a good culture does not work to create a good culture. So there are building blocks that you can do, which are, so taking that second thing around building a good culture, around creating the environment and that recognition of acceptable behaviors, etc., can build up on changing culture, but it does take time. And then the kind of advocacy and lack of use of evidence. So I have been in so many meeting rooms for so many years where people, it's often the naysayer or the constipator within a group who is sort of saying, show me the evidence of why this works. You have to do that in order to stop that blockage. But a lot of the work on things like alcohol cessation or smoking cessation, or people who work in policy and advocacy change, is saying actually you need to find the thing that the particular tribe, what their belief system is, and build upon belief. So it's a really complex area, and if I can find some research, just send over to you. But if you think of one thing, it's that evidence is necessary, but evidence does not change people's behavior. And as the way we're all brought up as kind of evidence-based people, it becomes quite uncomfortable. But it's a good example of how the thing that works isn't necessarily the thing that you believe, it's what other people believe.
Yeah, there's a job there to persuade, convince, and be compelling as well, but also understand what makes people tick or raises antibodies, for want of a better expression. But thank you for that response and for the question as well in the chat. Keep those questions coming through, and if they can't be answered now, we'll try and get our speakers to respond to them afterwards. But it's now time for our break, and thank you once again, Jonathan, just for those insights and practical examples and resources as well for people to have a look at. So next we have Emily Leon, a deputy designated nurse and actually a health equity fellowship alumni from last year's cohort 1. So Emily will now help us shift our focus from a bit of theory, as we heard from Jonathan, with a bit of practical application and signposting to some tools, but showing us how QI with a health equity lens applied can make a difference in improving access to healthcare information for children in care, care leavers, and their foster carers. So a powerful initiative of how QI can be applied to population health. But I'm not going to say any more about that. I'm going to pass the mic to Emily to talk us through this amazing project.
Lovely, thank you, George. So good morning, everyone. As George has said, I'm Emily Leon and I work at NHS Sussex as a deputy designated nurse. My specialism is children in care and care leavers. And just to note, I've been a registered paediatric nurse for nearly 20 years and also a nurse in specialist community public health nursing for 15 years. I just calculated shortly ago, which was quite surprising for me. So today I just wanted to talk to you about a project which I completed as part of my Health Equity Fellowship. And it was designed to really help improve and tackle the health equities and inequalities faced by children in care and care leavers in Sussex. So firstly, I just wanted to give a little bit of a background about who children in care are, because some of you might not have come across that term before. So a child who's been in the care of the local authority for more than 24 hours is legally known as a looked after child. That is a legal term. So nationally and locally, we try not to use the term looked after child purely because it gets abbreviated to LAC. And LAC is a term that our children in care and care leavers consistently say that they do not like because it infers that they're lacking something. So you'll hear me in this presentation refer to them as children in care. And that is something that I advocate that you all do if you ever do talk about this group of children and young people. So the majority of children, around 66%, enter care because they've been abused or neglected, sadly. Some of the other reasons can include a child with profound learning difficulties, and if they require respite care that's away from their family home for a significant amount of time, so they might need to access a residential setting for specialist needs. They would also be deemed as a child in care, although for them, their parents would keep that regular contact and that parental responsibility for them. Some of the other reasons include family breakdown and sadly, obviously, parental death as well. So another group that we include when I talk about children in care are unaccompanied asylum-seeking children. We have quite a few in Sussex and certainly nationally. So these are young people under the age of 18 who travel to the UK to ask for asylum. That's due to fear of persecution in their home country, and they've become separated from their usual parent or carer. Okay. So this graph just shows the population of Sussex here. This is our general population on the actual map there. And then in the boxes, you can see the child population and in turn, how many of those children are actually children in care. So in Sussex, we have on average a total of 359,000 children and of which around 1,935 are children in care. So obviously these numbers do fluctuate year on year. We tend to see an increase year on year. We have just recently had our figures, so I haven't updated the slide to reflect the latest figures, but it has increased once more again, which is often expected. And it's just to note as well, we also have lots of children in care which aren't reflected in these numbers on the screen that are placed in Sussex from other counties. So we have lots of children living here that are children in care from all over the country, and that may be because they can't be placed in their home county or due to lack of placement. So it's just to give a bit of an overview of who this group are. So we have children in care, and we also have who we call care leavers. So care leavers, as it says on the screen, they are young people who are aged between 16 to 25 who have lived at some point in care for a minimum of 13 weeks after their 14th birthday. So we do have many care leavers, as you can imagine. And also just to note really that just because someone's turned 25, it doesn't mean that their kind of care experience ends. So anyone over the age of 25, we call them care experience. So there are many, many care experienced adults living in Sussex. And it's just to kind of note that the trauma and the background and their experiences that they've had can often move with them throughout their adulthood and stay with them for life, as you can imagine why. And I just wanted to highlight as well that all the local authorities, this is nationally under the Children's Social Care Work Act, are legally obliged to offer our care leavers a local care leavers offer. And in this care leaver offer, it is things to support them with their health and social care. So it might be things like funding to access further education or transport to get to college. It might be support to go to job interviews. It might be gym membership. So it varies slightly depending what local authority they're living in, but the overall offer is always to help improve their social and health inequalities and give them the best start in life as they transition into adulthood. As one of my colleagues touched on earlier, transition is a very tricky time for any child or young person, but particularly for this group who often lack a parental advocate, as we would advocate for our own children and be there financially for our own children. This group can lack that, so they are extra vulnerable. So as you can imagine, anyone with care experience is at increased risk of health inequalities and health inequities. So this is just a snapshot on the screen of some of these more common issues that we see. So nationally, around 45% of children in care have a diagnosable mental health condition, but actually around 70 to 80% of children in care have a recognisable mental health concern. So that might be mental health, self-harm, low mood, etc. And we do see that frequently reflected in practice in our children in care. They're more likely to have multiple dental extractions and poor dental health. This is due to experiences or perhaps lack of supervision and parental guidance that they may have had in early childhood. So often they will enter care with poorer dental health than other children their age. And they're more likely to suffer chronic illnesses due to experiencing multiple adverse childhood events. So adverse childhood events, we call them ACEs, is kind of as it sounds really, that's traumatic experiences that they've been through. So that includes child abuse, it includes witnessing circumstances with their parents, for example, like drug use, etc. So we call those ACEs. And I'll come on to those in a little bit more detail shortly. So in recognition of the inequalities this group can face, Sussex and our Core 20+5 document, in Sussex, we're really fortunate that West and Brighton and Hove have recognised having care experience as a protected characteristic. And this is really positive because it means that there can be a real focus now on this group and some of the disadvantages that they face, but also the impact that this can have on their health and their futures. So there is work underway and we're looking forward to seeing what that looks like as time goes on to really support this group of children and young people. So that's what's going on locally in our system. And then I wanted to share this with you to build a bit more of a picture too. So this really depicts that everyone in health and social care has a role in improving health outcomes and social outcomes for our children in care and care leavers. And these are just some of the key professionals that might be around any individual at any one time. There can be many more as well, including voluntary sector workers too. Some of the key workers here, which I'll talk about as well during this discussion, are the specialist nurse and doctor teams, and also the social workers. Those are really, and school as well. Those are our partners that really work directly and daily with our children in care. So they have a massive influence on the project that we are about to talk about. So we really wanted to understand with locally in Sussex, what could we be doing in health to improve outcomes for our children in care, because they are consistently, as they are nationally, still experiencing health inequities and health inequalities. So we really wanted to look at what we can do. And where best to start than actually asking our care experienced children and young people themselves. So we did exactly that. We held a participation feedback group who consisted of care leavers, so they were aged 16 to 25, and they gave us some fantastic feedback. We asked them what would be helpful, what is stopping you accessing health services or health information. And some of the feedback was actually they found health quite an overwhelming place to access at times, particularly the online world. As we are all aware, Google can be quite a bane to health services at times in terms of the amount of health information there is available on there, and also the conflicting information that's on there. So when you're signposting a child or young person to this who might not have that kind of guidance that we would have for every other child that perhaps isn't in care, they can find it quite overwhelming. That was the feedback that we were having. So this group asked us to design a specific website that's just for children in care and care leavers in Sussex, where they can access all relevant health information links, so links to health websites, videos that are relevant for them, and local services in one place. That's what they wanted. So that is what we have done. And certainly have aimed to do. And it's been a really exciting project to be a part of. And our care leavers have been on this journey with us. So I'll talk you through briefly now, just for time, our project phases. So our first project phase started with the need for the website identified by the care leavers. This then led me on to, and part of our fellowship was looking at an EHIA. So I completed an assessment in my role to really home in on the protected characteristics and to make sure we weren't excluding any groups. So it really made me consider every element of our project and the website and how we could be inclusive to make sure it was accessible for every child and young person. So we have a whole mix in our population, obviously, as we do in the wider children and young person population. We have many who have disabilities, neurodiversities. We really had to be very thorough. So once we got through that process, we then had a discussion with our key initial NHS Sussex stakeholders. So that included also our providers, that should say on there. So those were our specialist nurse and specialist doctor teams for children in care that are in all of our provider services, so East, West and Brighton and Hove. And they were fantastic. So they told us what content they think should be on there in terms of day-to-day when they're meeting the children in care and what advice they're giving their case children on their caseload. So we brought together all of the websites and resources that they wanted on there. And then to give it some structure, we based the website content also in terms of sections, which I will show you shortly, on the core 20+5. So we really wanted to make sure we were hitting those key points on there and also reflecting practice that was from our feedback from our specialist nurses and doctors. So, and then also paired with what our care leavers at our participation group had told us key areas they wanted to see. And one of the areas they wanted to see, which we hadn't considered thoroughly, was a section specifically for foster carers and also the professionals working with them. So we had considered having a section on the website for foster carers, but not necessarily for the professionals. So like the social workers, like some of the nurses, but or any practitioner that has contact with them. So that was really valuable from them. So after we had this feedback from our stakeholders, we created the draft website. And then we held another test and evaluation group with our participation group of care leavers. And they were excellent at giving us really rich feedback. Again, they told us what they liked, what they didn't like, and that enabled us to make changes. They also asked us to ensure that we worded certain sections. So there's a section for special education, children with special educational needs or disabilities. And they really wanted us to be very careful about the way we worded that. So in our participation group, there were young people that had SEN needs. There were others that had neurodiverse needs as well. So we really tried to capture their voices within our website content. So after that, and after we were satisfied that our participation group were happy with the content, we then went to our wider stakeholders, so our local authorities, so people like our social work colleagues and their managers, to really look at how could we be sharing this across our wider system. And they've been excellent, which I will come on to phase 2 now, because from those meetings and sharing it with our partners, it's helped us go into our second phase of the project, which has been the local authority wanting to use our website as part of their care leaver offer that goes out to all their care leavers as they leave care. And that's been really valuable But to enable that to happen, so this is one local authority area in Sussex, this is West Sussex, they enable us for this to happen. We had to really work in partnership with them to make sure the content on the website reflected social care needs, but also health needs. So it was a real partnership working piece. And now the website content has been tweaked slightly to reflect what the local authority advise children and young people as well, and some of the services that we weren't even aware of it in health that support the needs of this population. So it's been so helpful to be able to do that. And it's also meant that now our website has a real feel of an ICS approach, which is what we wanted. That's always our goal, is to have that, because partnership working is so important with tackling health inequalities for such a big group. So so far we're just entering the second, we're just leaving the second half of this of this phase, and we'll take that forward, which I will go on to next. It's also just to note, part of our second phase was for me to have website training completed by our website team in the ICB. So it now means I can edit this website and maintain it for our team, which has been really, really good. So this slide here, this is just a video which just gives an overview of our website. So this is what it looks like. This logo, by the way, they designed, our children in care and care leavers designed that logo. That's exactly what they wanted. The website can be translated into other languages, so they can press that button and they can choose a language. These are the sections that it's going through now that are available on the website. And again, these are sections that the young people wanted us to break it down into. So it's all age appropriate. They can contact their children in care specialist nurse teams on there. And there's also quick links to their care leaver offers in the area. And there's a link to our feedback platform for children in care as well. So if you go into, I think it's going to go into children aged 5 to 8. So this section, as it sounds, is for children aged 5 to 8, and all the sections here, there should be some videos that pop up on there. There's some sections about keeping healthy, how to keep your teeth healthy, and some really nice videos that the children in care thought that this group would like. We also had to make sure that the videos had a bit of an evidence base. So although it might have been what our participation group liked, we had to kind of go through and screen the content and make sure that it was appropriate and it had a good and correct health evidence base for them. Then if we look at the older section for 13 to 18-year-olds, which is probably our biggest cohort of children in care, it gets a bit more detailed. Now, this content is obviously based on Core 20+5, but it's also based on common reoccurring themes that we see in our serious case reviews for children, and things might go a bit wrong for them, but also common health issues that we see happen in our health assessments that they have completed by their specialist nurse every year. So mental health is very big. Gender identity was a common problem, bullying, etc., and friendships, and obviously sexual health and relationships for this age. We also like to cover keeping safe for them as well, and so that gives lots of advice. There's also a section on there for our unaccompanied asylum-seeking children that I've mentioned earlier, and there's a link on there to signpost them to any age-appropriate information on the website, but this is just specific information for their group that is available on here. So immunisation specific for them, we felt was really important for them to have. And then briefly, we've got a section for children and young people with special educational needs or disabilities, which is quite a large proportion of our children in care. They are overrepresented in terms of the children and young person population. We have quite a high number of children in care that have an educational healthcare plan. It's actually above the national average, so that's quite significant for Sussex. So there's lots of resources on there. And then bedwetting and toileting is quite common, so we've just tried to really think about what they would need. And then finally, there's a section for foster carers and professionals, which, as it kind of describes, is information for them that is specific for carers and professionals supporting them. Okay. So in terms of the impact of what this has had, children in care and foster carers and care leavers will hopefully have an increased accessibility to health information in one place. And we hope that this will help influence health outcomes and inequalities for this group. So we've started, this is the first quarter, these graphs on the screen here reflect the first quarter of data analytics from the website. This was the 1st of June to end of September. And in that time, the website received 852 views. and that was 187 users. But what that means is that out of the 187 users, they have come back to access other sections of the website on more than one occasion. So that's been really promising. You can also see on the table on the left here what areas of the website they are accessing, and the care experience, so the care leaver section for 18 to 25-year-olds has been accessed the most, which was really interesting. And I do wonder if that's reflected in the link that we now have with our local authority and it being on their care leaver offer. So we are expecting the data from our next quarter soon, so it'll be really interesting to see how it's reflected and its usage maybe has changed. So I'm hopeful. And these just briefly touch on, because I'm aware of time, our next steps. So continue to use data analytics from the website to identify what areas of health users are accessing. We will continue to maintain the content. And it's something I'm really keen on doing. And we need to just find some funding, because we believe that all participation assistants, children that are participating in our feedback group, we do like to pay them in some way. We don't believe in them doing it for free, particularly in care. So we'd like to hold another test and evaluation group to get their feedback on now how the website is, almost 1 year on. And we want to liaise with the other local authorities in Sussex to involve them in content and encourage even more kind of an ICS sharing approach. And then finally, we need to further advertise the website. Although we have an advertising campaign, we need to continue that and see how we can increase it. So via foster care newsletters, for example. And then finally, this is just the QR code to our website if you wanted to take a look. And I'll also put a digital link in the chat for you if anyone would like it. And our email address is there if you have any questions. Thank you.
Fantastic. Thank you so much, Emily. And what an incredible piece of work in a relatively short space of time. And I guess I've got some added insight given the connection to the fellowship, but amazing, isn't it? And two things stand out for me, or at least one I'll focus on, is the focus on co-designing solution and linking back to what Jonathan said earlier, not underestimating the power of qualitative data. In the absence of charts, you've got the voices of the people who are underserved and are able to clearly articulate what they need. So involving them from the start, I guess, helps remove some of those barriers or understand what the unknown is. And you've created a wonderful tool like this website. And it's an empowering approach, isn't it? But also ensures that the interventions that we design are meaningful and relevant. So co-design isn't just a method, it's a mindset. Again, alluding back to what Jonathan said. So thank you so much. If there was one message or one plea or rallying cry you could give, Emily, to participants on the call now who might be embarking on a change or a project of that involves co-creation or co-design or co-production to improve the health and the experience of the population they serve, what might that be?
That's a very good question, George. Thank you. It would be to find the right person in the right place to be liaising with. So we knew we needed our frontline staff to be involved in the creation of this, but we equally understand the pressures that they're under. So we needed to find the right person in their teams to get that information from and their involvement in terms of stakeholders. And also just bear in mind that a project it should be a continuous cycle. And as this is going to be out live, hopefully for the foreseeable, it will be something that we continually need to be reviewing.
Fantastic. And you've already got some fans and wonderful comments in the chat about the website and the usefulness of the resource, and by the sounds of it, for colleagues across the system who will be signposting to it. So really encouraging and timely talk, actually. So thank you very much, Emily. And wow, time flies when you're having fun and learning lots, but I'm sure you're all probably shivering and waiting to either go on to your next call or hopefully a walk to get a break from the screen. But before we do that, I mentioned we're going to be doing the interactive poll once again, just to gauge how your knowledge and perhaps your confidence has shifted following what you've heard on our topic today, quality improvement in population health. So the Slido link is in the chat, as is the QR code in front of you on your screens. So whatever device you've got, phone, tablet, or whether you're on your laptop, please would like to hear from you to see whether or not your knowledge and confidence has shifted. So in a second, we're going to have Slido pop up to see what our participants are saying. So we'll give that a few moments. So from those who are responding, we've seen a good amount of knowledge and confidence. So an encouraging shift from what the responses we had earlier this morning. We'll wait a few more seconds. And whilst you're answering that question, would also like your feedback generally on today's session, on the content, and on the experience as well of using the technology that's been available today, namely Slido, amongst other things, and other questions, just for us to gauge how we can further build on these webinars and bring you content that is valuable, useful, timely, and applicable in the real world, more importantly. So we'll just give it a few more seconds for you to respond to this question, and we'll keep the poll open as well for people to respond to the other questions and provide their feedback. Okay. So I'm not going to keep us for much longer, and I'll now pass on to Joe, who's going to share some closing reflections following what's for me has been an amazing morning and insights from our speakers. So Joe, over to you.
Thank you ever so much, and thank you to Lucy and Jonathan and Emily and sharing the work they've been doing and helping us understand QI more. Thank you. It's been a great morning. Thank you all for sticking with us and staying and participating in the session we've had today. The stories and insights and the examples that we have really show how QI is critical, really. And it's not just a tool for better care, but as a way to address the deep-seated inequalities that exist within our population. The children in care, I just made sure I got the right term there, Emily. Thank you for that note. We also invested in some to pay for prescriptions for children we've looked after, children in care, for their prescription charges, and we got some great feedback about what that meant to them, actually not worrying about if they could afford their medication or not. So, and that was a small amount of money, about £5,000 that we spent doing that, just to help tens of children be able to access and pay for their prescriptions. So it doesn't always mean big money. It often means just us thinking about how we can do things better. And it's not just about technical processes, but it's about our people, it's about us and how we collaborate with each other. Don't take it on alone, I think is what Jonathan was saying, wasn't it? You know, seek your allies, work together with people and really look at how you can achieve this work. And break down our organisational boundaries. I mean, that's what this ICS is all about. It's us making sure that we work together on these things and don't worry about who employs us. Also, the tools and skills we already have are really powerful. You've all got great knowledge and experience and networks and relationships, so let's really help work together to make sure that we can highlight and use this capability and creativity, which I'm sure is out there, to move this forward. And also QEI is for everyone. So I saw Joe Rogers about the Commissioner's comment, and I'm not sure if we addressed that for you, Joe, but let's have another conversation about that as Commissioners. It is for all of us, but how do we improve? How do we commission differently? How do we learn what the evidence base is saying and learning from what our providers' colleagues are doing and what makes a difference? And see if we can change the way we commission and also change the way we deliver. So thank you ever so much for being with us today. I hope you've benefited, as the Slido suggests you have. Sussex Population Health Academy is here to support you. We have other resources on here and other training packages as well. And let us know if there's anything that you'd really like to see that it maybe isn't there. We are developing all the time, and we want to make sure that we are meeting your needs to be able to deliver on population health and help us all to address the inequalities in Sussex and deliver equitable care for all. So thank you for being part of this important conversation today. Let's keep it going. Appreciate your time and your commitment to this endeavour, and look forward to meeting you at different places or in regular contact. So thank you ever so much, and back to you, George.
Thank you very much, Joe. And yes, absolutely. Very, very timely, particularly in these constrained times where we're constrained in terms of time and resource and funding, amongst other things. Those organizational boundaries shouldn't inhibit us from improving and continuously improving the experience and the access of the populations that we serve. In closing, so there is more to come. There is, it's not a trilogy this time. We've got 5 webinars, and the third one is on data for better health outcomes, which I'm sure will be interesting. We've seen some charts already and heard about qualitative data, but we'll be exploring this a bit more and trying to learn how to leverage, how to make the most of data and digital tools to address the disparities that we see and we experience, or the people that we serve experience, and reduce those health gaps. And Joe made a comment earlier with regards to another comment from another Joe in the chat with regards to commissioning. So the webinar in February, which is going to be on equitable commissioning, hopefully we'll try to address that. So, and of course, Lucy shared the commissioning toolkit as well. So lots of resources and lots of opportunities to connect and learn and hear and share, and ultimately improve and transform the lives of the people that we serve in Sussex. Now, we're not going to have another webinar until 2025. I mean, where's the year gone? So ahead of that, I hope you have a good rest of the day, good rest of the week, and also a happy festive period when that comes. Can't believe I'm saying that, but we're almost there. And a happy new year when we get there. And prior to that, of course, we're here, the Academy team's here as well. So if you've got any questions, contributions to make, and feedback, we've got the Slido poll, but also feel free to contact us directly. And until then, we wish you a good rest of the day and take care.
Thank you, George.